So I think we could probably jump into it now. We've got a really great number of folks joining us today. So I think before even kicking it off, like a huge thank you to everybody that's here for kind of your interest in this important topic. And second, a huge thank you to Ohio Council. It's been, I think, a pleasure for our organization to be in partnership, and are really excited to be able to continue achieving our mission of really promoting the importance and use of measurement-based care in clinical practice. We'll jump into the conversation here, but before I do, obviously, big thank you to everybody here, big thank you to the Ohio Council, and big thank you to Nathan or Dr. Henninger and team at I Am Boundless. We're very excited about the collaboration, and I think you're going to hear quite a bit more about it today. In terms of an agenda here, I'll just kind of lay out the agenda, and then Nathan and I are going to drive different parts of this conversation. So first and foremost, some introductions, so you have a sense of who I am and who Nathan is in our organizations. Number two, we're going to spend a bit of time, probably 5 to 10 minutes, going through really the question of what is measurement-based care, what's the research behind it, what's the potential for impact. And I always find it really important to define that up front, because this is a concept that can often get rolled up or confused into broader categories around measurement or data or outcomes or evaluation. But MBC is a pretty specific clinical process. Then really the core of this conversation today is the backdrop being why is Boundless making this investment into MBC, which we'll talk more about, and allowing that as a backdrop for really a conversation, and trying to encourage as much engagement from everybody here as possible, and try to make this session as practical as possible and tangible as possible for how other organizations might think about different use cases for measurement-based care using the examples Nathan's going to provide. And then leave a bit of time at the end for discussion and Q&A, but really we sort of want that Q&A and discussion to happen throughout. And before we jump into anything further, one housekeeping item. We're going to use, in terms of Zoom features, we're going to use the Q&A function for questions. And the reason we like to use that is because everybody can upvote. And so as opposed to Nathan and I having to filter and do all of this live, we're going to ask everybody here just to upvote the questions that are most, most interesting or impactful for yourself or your team. And we're going to try and do as much of this in flow as possible. So we're not necessarily going to wait to the end to answer questions. So please use the Q&A, put questions in early, and allow people to kind of upvote, and we'll make sure we spend time on the ones that are most interesting to the group. And then last piece, you could use the chat as well. Always encouraged, but we're going to use the Q&A for questions. So thank you very much. Without further ado, Nathan, let me pass it over to you for I think your introduction and a bit of background on I Am Boundless.
Yeah, thank you, Simon. My name is Nathan Henninger. I'm the State Director for Behavioral Health and Educational Services at I Am Boundless. I Am Boundless is, or next year will be right around $160 million a year health and human services agency. A lot of our roots are in the IDD and autism world, with kind of complementary services focused on individuals with complex needs. So we do a lot in the multi-system youth engaged space. We are a CME in catchment area M for Ohio Rise. We have locations throughout the state and provide a broad range of behavioral health services, IDD services, as well as some primary care and dental in the greater Columbus area. So thank you for having me.
There, just looking for my mute button. Thanks, Nathan. For those that I haven't had the chance to meet yet, my name is Simon Weisz. I'm the president at Greenspace Health. It's a fancy title. Really, my day-to-day role is external in conversations with behavioral health and substance use organizations. to think about, design, plan for measurement-based care implementations. So leading the clinical partnerships team at Greenspace, but with most of my time really external, working with organizations directly. Greenspace as an organization, we were initially developed out of a couple of academic research hospitals, really with the sole purpose of bridging the gap between research and clinical practice when it comes to this concept of measurement-based care. And, essentially, how can we bring the benefits we're seeing in research into practice? And there's a lot that goes into that, which we'll talk more about. But when we think about our role, part of it is technology, right? Being able to make the workflow seamless, make the data more impactful or usable, and really enable measurement-based care without asking for a huge manual burden on the clinician or care team or administrative staff. So technology is absolutely part of this, but just as important is the implementation and change management side. I think one of the greatest learnings for our team from the early days, we've now done this with 500 plus organizations where we've successfully implemented measurement-based care. But one of the learnings in the early days was if you build a best-in-class technology and we handed it over to partner organizations, maybe 2 in 10 or so would actually be highly successful in getting measurement-based care implemented across the organization at scale, having the impact that they were looking for. And I think our team recognized the opportunity to learn and kind of like build the toolbox of strategies and approaches and really build our own internal understanding to be able to better support each organization. So today, having been able to learn from 500 of these implementations, there's so much more we get to bring to the table with a partner. And interestingly, along the same trajectory over the last 7 or 8 years, in the research, there's also been a huge shift in the research where originally there was a lot of focus on what's the benefit of measurement-based care? What does good measurement-based care look like? And in the past few years, there's been a whole body of research just on implementation of measurement-based care, which again, in our minds is equally as important as technology and workflows as anything else when it comes to doing this really well as an organization. That's about all I'll say on Greenspace. We do work with a very wide range of organization types and client populations. And I think in this conversation with Nathan, it'll also give a sense of, how we think of supporting populations that might not be your traditional high functioning outpatient, behavioral health clinic, where I think we've seen more research and more focus in the topic of measurement-based care. So that's enough about me and Greenspace. And let's jump into kind of the first agenda topic. Essentially, let's define and talk a little bit more about measurement-based care. So I find this definition on the screen here a really clear one and helpful one to just set the stage. It's from a Scott and Lewis article Scott and Lewis paper in 2015. MBC is the routine collection and use of client-reported progress measures throughout treatment to guide clinical decision-making. And there's a few concepts in here that really jump off the page for me personally. Number one, it's this idea of routine collection. Number two, client-reported progress measures. And number three, the concept of it being used to guide clinical decision-making. We do a lot of work in addition to supporting organizations. I've also done a lot of work in partnership with researchers or other experts in the space to, I'd say whether it's supporting organizations with education and kind of implementation of measurement-based care, or whether it's focused on really moving the needle in terms of adoption across the sector. And one of the groups we've done a lot of work with is the Yale Measurement-Based Care Collaborative, which is essentially 4 researchers out of Yale University that are I'd say the leading voices in North America on implementation of MBC. And Dr. Resnick leads the full kind of MBC implementation work across the VA. She's a huge voice in this sector. And I like to pull this quote in. I think she makes it pretty clear, but as opposed to MBC being about data collection or outcomes, it's very much core to the treatment process itself. And so it's a clinical exercise first. And some of the language in here around MBC as the foundation for good mental health care, everything's built on this foundation. And specifically when working with the client, helping to make sure that treatment is going in the right direction. Now, I think there's in addition to defining, sometimes it's helpful to sort of contrast, right? So what is MBC and what is it not? I think traditionally in this sector, there's been a nice shift towards the use of assessment tools, but that doesn't necessarily make it MBC, right? So the use of assessment tools for data reporting or in a pre and post model or really clunky manual provider report kind of tools wouldn't fall into kind of the research definition and how we think about measurement-based care and the value that it can drive, right? So when we think about MBC, it's very much around a clinical process driving clinical value, but the consistency of data collection, the specificity to the client, which we'll get into, end up generating a very, very, very useful data set for an organization to leverage. So there's this interesting dynamic where when we partner with an organization, more likely the kind of the buying decision is made at the CEO, executive director, leadership level. And their investment is because they want to have access to a really high quality data set on outcomes to be able to better manage care internally and also communicate externally. But ultimately, measurement-based care is about clinician and client. And without doing that part really well and focusing on what is measurement-based care, what are the core components, how do we drive clinical value, we're not going to get the adherence, the buy-in, the quality of data we need to then have that data set that leadership are often looking to make this investment on. So I think that's just a really key point in that there's two concepts, and ultimately MBC is about that clinical process and clinical value that can be driven. And shifting to this next slide, I think if a follow-on question from what I'm talking about here is, okay, so what does a good MBC look like? What does the research say, this needs to be? And in trying to translate this from research to practice for organizations, our team likes to break it down into kind of like simple 4 C's. So we need the use of measures to be consistent throughout treatment. This is a shift away from, I'd say, like a more traditional pre and post model. Hard to imagine this actually affecting a treatment trajectory or becoming part of the conversation if it's just pre and post. And ultimately, that post measure is about reporting. It's not necessarily about clinical care. So it's about how does this become consistent throughout care. Number 2, to the extent possible, we want to customize the assessment tools and measures used to the presenting issues, symptoms, and goals of the client. This has a massive impact on clinician buy-in and way more than people expect. I think there's a really, really strong link between clinician perception of utility and their ability to have autonomy over the measures selected and used. We also see a really strong link between client engagement and also from this kind of customization of measures, we're seeing data come out about a link between customization of measures and outcomes. So when this is from a massive data set in the UK, but when a clinician chooses to adjust a standard package of measures and customize it to the client, we're seeing a massive bump from, I think it's like high 30s to low 50s in terms of % of clients seeing reliable recovery. So a really, really good marker of quality MBC and also quality care. And the number 3 and 4, client visibility. Again, to the extent possible, giving clients insight and access to their own information, to their own visualization of progress. It's something that's been pretty core to the Greenspace application, and we've seen a lot of impact from that. And then number 4, at the end of the day, this process needs to be collaborative, right? It's between client and clinician and needs to be driving value for their conversations and a part of their conversations. So that's kind of my, I'd say, simplified overview of like what goes into quality MBC implementation. And now I'll shift for kind of the last slide I want to talk through before taking a bit of a pause, a little bit of an overview on the research. And on the right-hand side, there are some big numbers in terms of the potential impact from measurement-based care. I'm not going to spend time there. I think the more interesting research conclusions are on the left. And both of these, call them research conclusions, are perfectly matched within our data set. And like what in our minds is ultimately the largest measurement-based care data set in North America at this stage, we're seeing these conclusions reflected. So the more assessments that clients complete, the more they improve. Here's a little visual from our data set. On the left hand, we're seeing number of assessments completed by client. On the right hand, we're seeing percent change on clinical symptom measures. So seeing a pretty strong correlation there. I certainly wouldn't say there's causation, but clearly client engagement with measurement-based care, so more assessments being completed, client engagement with measurement-based care has a very strong correlation with positive outcomes. Second, the more often a clinician reviews a client's results, the more the client improves. Again, we're seeing this in our data set. The more often a clinician is going in to look at assessment results, and therefore they're bringing it into the conversation, the better the outcomes. Interestingly, there is also a correlation between these two concepts. So the more often a clinician reviews a client's results, the more assessments a client completes. And so you've kind of got this triangle of, in some ways, like 3 really important data sets for effective MBC implementation, but ultimately clinician buy-in and engagement and perception of value from the process is going to impact client engagement with the process. And both of those factors are going to impact outcomes. And so when we distill this down to like, what is measurement-based care? At its core, it's a clinical process that is shown in research to drive better outcomes, better client engagement, and some other benefits we'll talk about later. But by doing so, we are also then going to generate a very, very useful data set to be able to better manage care, better understand what's happening, better share insights across a care team, and ultimately have data on what care pathways and programs are most effective for whom. But it all starts with the clinical process. So I will pause there. My next slide here is really an open question slide. I want to, I think, give myself a breath and then also put a poll out to the group and get a bit of a feel for who's in the conversation, get a bit of everybody else's perspective. But I'll give everybody a moment. If you have questions, throw them into the Q&A. And at the same time, I'm going to start a poll that'll be available to everybody now. Relaunch. Perfect. And maybe while we do that, Nathan, I will open it up to you to just give it to you to say, hey, is there anything else you'd add to that intro on MBC, or when you're sort of thinking about this for Boundless, anything else that really stuck out to you in terms of kind of how we're thinking about defining MBC and process?
Yeah, I think I would just kind of key into the idea that it's an ongoing process that drives treatment. I have done a lot of work in the ABA space, and when we think about how we devise and guide treatment, there's an immense amount of data collection that happens in that space. And so, kind of thinking about how to leverage that approach in other populations, in individuals in the IDD-ASD space specifically that perhaps don't require that high level of intervention, but are often left out of the type of research that we do. And maybe for a little bit of context, as we're waiting for the polls to come in, my background is clinical psychology. And although I'm in kind of the IDD community mental health space now, I spent a lot of my time in academic psychology and or particularly in academic medical center settings. And so the kind of process of how do you measure what you're doing, how to bring evidence into the care that's being provided, particularly when there's not enough bandwidth to provide all of the services in the way that we have done traditionally is of immense interest. And so, when we talk a little bit about how Boundless is approaching this, what I'm hoping to do is kind of key into some broad broad categories or issues that are not unique to us, but are relevant to everybody on the call and the agencies that you're coming from.
Thanks, Nathan. So I've gone in, I've shared this poll out. Before we chat through this quickly, I've shared it so everybody can have a quick look at what the responses are. There was a question that came through from Jeremy. And I'll say answer live. So what kind of assessments are clients doing? I'm happy to speak from the Greenspace side. I think we could talk a little bit from the Boundless perspective as we get into the examples. But from our perspective, it is measurement-based care is more about process, less about specific assessments. So on the Greenspace application, for example, there are 300 plus assessment tools within our database that clients are leveraging. And our team is actually agnostic to the tools that are used, and we're often adding or customizing for specific organizations. Ultimately, the categorization, if I'm just thinking broad strokes, is going to be, assessments looking at clinical symptoms, assessments looking at functioning, assessments looking at substance use, assessments looking at therapeutic alliance are probably the four most common. And then maybe I'll create like an other category where you've got things like, relationships or social determinants of health or other factors. I think ultimately the key with measurement-based care is the specific assessment tools are primarily going to be client or caregiver completed. And they're largely going to be shorter form because we're thinking about consistent completion. So not 100 plus question diagnostic measures, but shorter form measures. And then maybe the third component is validated to track change or progress over time. So not focused on diagnostic, but focused on tracking severity and progress as people move through care. So some examples that would be very, very common, in adult settings or adolescent settings, you'd see like PHQ-9 and GAD-7. Again, in this space, there's lots of opinions on different measures, but those would be a couple of common ones, including like a PCL5 or the adolescents, the UCLA PTSD-RI when we're talking about trauma, or a TSC is another trauma one. Like there's a massive space when it comes to the measures, but from our perspective and the research perspective, it's process over the specific measures. And so we want measures that are tailored and validated for the population and programs that we're supporting. In terms of the poll here, I thought this was pretty interesting. So pretty much a 50-50 split of organizations that have implemented or have tried to implement measurement-based care versus those that have not. Interestingly, it's sort of only 23% of organizations on the call have hit like the yes category of implementation. When we dig a layer deeper on that 50%, it's a little bit all over the board in terms of like a level of success of that implementation, but most are a 3. So most organizations that have implemented or have tried have not necessarily gotten to like an ultimate, like a super successful outcome from the implementation, which I think is interesting. And there's a whole other conversation and some components we'll talk about later around how to support implementation. And then in terms of prioritization, I think I was pretty optimistic to see like, for the vast majority of folks here, it's sort of a 3, 4, or 5. And for over 50%, it's a 4 or 5. So that's interesting. And I think kind of mirrors what we're seeing in the space, right? Where, the adoption curve for measurement-based care, every year it's a higher percentage of organizations that have implemented and successfully implemented, but that has continued to increase. And I think we're starting to see now, 30, 40, 50% of organizations across the sector really being ready to prioritize this, and particularly around the shifts towards value-based care or more accountability for funds or alternative payment methods, which we'll get into. So thank you, everybody. That was really helpful, and hopefully helps kind of set a bit of the stage of as we get into the next part of this. Nathan, I'm gonna transition it over to you here to talk a little bit about the Boundless story and then the 4 categories we wanna jump through.
Yeah, actually, I think, Simon, if you can just bump to the next one. I think in attending lots of presentations and then participating in some from the other side, one of the things that I really think about or try to accomplish is a takeaway for the people listening that is not just that was a great story. So while I will talk about this in the context of the decisions that we're making at Boundless, I'm hoping that by kind of organizing it into these 4 broad categories, with number 4 maybe just substitute in whatever specialized population you happen to work with, that there are meaningful takeaways. And so we're going to talk a little bit about the preparation for value-based care and alternative payment models. Obviously, in the state of Ohio, other places in the nation, the shift away from typical fee-for-service is very much underway, particularly in the behavioral health space. Lots of us are engaged in some type of value-based agreement or alternative payment models, even if it's focused predominantly on kind of incentives as opposed to shared risks. I think, looking at whole person care in some areas, and this is particularly true, I think, in the IDD ASD space, high utilizers of behavioral health services, and good care is going to impact other spend, basically. So we may not see lots of symptom reduction, but perhaps can impact utilization of the emergency room or other health outcomes. We have a project getting started around some universal screening on a suicide prevention program, and being able to link that to measurement-based care for the individuals that screen high. And then again, understanding kind of how this approach works in the IDD-ASD population, particularly when we move out of the ABA space, and then how to leverage more aggregate data.
Well, let's jump into it. We've sort of tried to break this down into, a slide for each of these topics. And when Nathan and I were preparing for this, and this is sort of the ask to the audience here, we wanted this to be a little bit more back and forth. And so to the extent that, you want to use the Q&A or even the chat to engage, I think that'd be helpful. But Nathan, maybe I'll turn it over to you on just talking through this first component, and we can go from there.
Yeah, absolutely. So, kind of thinking about, again, this move to value-based care and alternative payment models, there's a couple things that stand out to me. So one of which is, understanding the quality of the care that we provide in a way that's not simply subjective. So to be able to objectively measure what we are doing and the impact that it has. And I will say, for myself, I think for our agency, hopefully for many of you on the call, I think our options here are to be active and kind of figure this out in partnership with managed care companies, or sit around and wait for somebody to tell us what good outcome is. I was on a call earlier today around a value-based agreement that is focused predominantly on HEDIS measures, right? And that's okay. Certainly is a good place probably to start and to dip our toes into the water. But at the end of the day, there's much more to the care that we provide than these broad kind of discrete categories. Again, not wanting to diminish use of antipsychotics or 7-day follow-up or health measures, but there's definitely more that I think we can leverage here. And so having outcome data that is not simply a pre-post, which again, if anybody has tried to do that, I certainly have been at agencies where we've tried to implement that, is immensely difficult to get compliance, to get relevant data, to get meaningful data, and certainly not data that drives care. Having it be part of the continuum of what you're doing day in and day out becomes important. I like the idea also of thinking about risk stratification or tiers. Again, like many agencies, we have a wait list, and it forces you, I think, to start to address issues of, what is an episode length of care, How long should we keep somebody in treatment? What models are, does everybody need an hour a week or every other week? What if we did half an hour twice a week for 6 weeks? Would we drive an outcome in particular populations? I think we're pretty far away from this, but I really see measurement-based care as something that can help kind of drive towards that discussion and really rework the way that we approach treatment and what it means to be engaged in treatment. And so, of course, the backdrop of this is what everybody knows. The population is aging, the number of individuals that need care is increasing, and our workforce is decreasing. Certainly on the direct service side of things, but again, I have to imagine everybody on the call has struggled hiring clinicians, keeping up with retention because there's always somebody else that's going to pay a little bit more. And so I don't know that that's going to change, right? So we have to lean into the way that we are thinking about providing services, and I really see measurement-based care as a huge tool to help us move in that direction.
Nathan, I might double click on a couple of the comments you made and try and throw some say some other kind of practical examples or use cases from that I've seen. So the last thing we're talking about here around patient flow or client flow through services has been a really interesting one. I think it, in some cases, has come up in a value-based care or payment model context, but I think more often is us working with an organization trying to solve the challenge of, we have people in programs that are there for 1 to 2 years. Our typical program length should be 2 to 3 months. And we don't know if they're getting better, if they should be with us. And it's taking up space for that wait list that's coming in, right? And I think many organizations think about their wait list and try and solve for the wait list, whereas like your biggest lever in solving for a growing wait list or access challenges is around discharge and clients in treatment. And so one of the models that I've personally found like most interesting have been some of our partner organizations that, rather than saying, hey, when you move below X score on this, symptom severity rating scale, you're a discharge. Like, you don't really want to bring those hard lines in. And I think that would make it really challenging for clinician buy-in, because I think we all understand, measurement-based care data is not the whole picture. It's not the whole story. It's a tool. But the model that has been really effective is essentially breaking down a care pathway and saying, hey, each client is going to get a block of 6 sessions to start. And then a clinician can choose to extend that client for additional blocks of 6 sessions or 4 sessions, or however you want to define this. And there's no cap on how many additional blocks of sessions can be extended. However, the one requirement is now when a clinician does want to extend to an additional block of sessions, they need to record in the note, either a new extension note would be created on the system or just in the session note, they need to reference the measurement-based care data. No requirement that somebody's above or below a score, but just reference that data. And we find that creates a really interesting, I'll call it like accountability check for the clinician. And, a double check on like, hey, should we continue with this client that, it's really comfortable to work with this client. We love working with them, but we now have a double check on like, what is their kind of severity and how much progress have we made from when we've started? And very quickly for clinicians, they're going to have a mental model that's created of like, what's the band of severity new people coming off the wait list are starting at that they're working with? And what's the band of severity where they're getting comfortable to discharge? You step up to call it a manager or leadership level, and all of a sudden you now have this data as well to bring into that conversation with clinicians. And so being able to look across a program and look at the bands in which people are being discharged from a presenting issue and severity level, look at the bands at which they're coming off the wait list. And then maybe one level further from an active management perspective, being able to look at a data dashboard and on the bottom right of the screen is an example, but look at aggregate data, maybe filter that dashboard by, clients who have been in treatment for 5+ months. and identify which clients are in the minimal or no symptoms category or mild symptoms category, and maybe should have been discharged if they're still in treatment 5 months later. But you can dig into each case, you could bring them to supervision, etc. So that's, I think, a really practical use case we've seen on how organizations have really drastically improved their patient flow and improved the rate of discharge, and ultimately using that data to help give confidence to the clinical team in doing that.
You know, when we had talked earlier, one of the terms you had used was the accountability to discharge, which I kind of resonated with me. Even going back to being a clinician, you always had those folks on your case list that maybe didn't come in every session or every 3, and you kind of left them in there. Maybe it's better than nothing. If they note you like they normally do, I'll use that to get notes done or eat lunch or kind of whatever the case may be, but not really thinking about whether I'm providing good treatment, or having a way of kind of thinking about that or measuring that, or even thinking about the people that are not able to access because that time is taken up. So yeah, absolutely.
Great. So I'll encourage people again, throw questions in the in the Q&A if you have them. Throw comments in the chat. I think that'll help turn this a little bit from lecture to discussion. But Nathan, you tell me, should we move to the next slide here?
Yeah, if there's no questions or comments, let's go ahead to the next one. And so whole person care. This is, I was thinking about this morning as I was driving into Columbus, and just being reminded of how old I am, that, when I was first training and first engaged in service, we still were kind of segmenting out, the idea that, psychological or emotional health and physical health or whatever were, somehow, different. Clearly the preponderance of data over the last number of decades have not only shown that to not be true, but have created some very compelling storylines around the impact of what we do in the behavioral health, mental health space on physical health. You don't really need to look any further than the ACEs study and the impact of trauma, shortening somebody's life. So I think as, we have looked at our particular population and trying to provide better integrated whole person care, and really thinking about really kind of a couple things. So one, going back to that idea of value-based care and understanding that some of what we do, maybe a lot of what we do, is going to be the cost savings is going to be seen in other areas. It's particularly true in the IDD ASD space, maybe a little bit less in some of the other populations. And so that, that we're not thinking solely about behavior change or, reduction of problem behavior or some, demonstration of coping skills, but thinking about what is that doing to overall quality of life and health and so forth. And so part of this then is this idea or discussion of, when you're looking at social determinants of health and the predictors of, utilization, broad quality of life, or whatever, how can we, map that against what we're doing in measurement-based care? And I really like that idea that Simon laid out in the last slide of kind of thinking about the episodes or even the tiers kind of in blocks. You're not saying to a clinician, hey, you can only do 18 sessions, or it should only take this. There is that flexibility to bring in the art, to bring in other issues. So perhaps we've targeted symptoms of anxiety, and school attendance has improved, but maybe there's something else now that has opened up that needs to be kind of followed up on. So again, understanding that flexibility of what's working for whom, and the impact that has. And there's probably a lot to unpack here, but that's definitely the approach that kind of we're thinking. Certainly has informed some of our decisions to move into primary care, to start dental, which we're ready to do if we can get a dental hygienist. So if anybody knows a good candidate, please send them our way. That's the only holdup that we have at this point. And looking to kind of press a little bit further into those needs assessments and the things that impact care and access.
Yeah, that's great. And I think the thing that always stands out to me when we're having the conversation about whole person care, it's one thing to be able to deliver services outside of kind of your traditional behavioral health, mental health, substance use services, and be able to bring in physical health services. But most organizations on this call probably are not doing that today. But it doesn't mean that you can't be providing or thinking about whole person care, right? So in the measurement-based care context, I think it's very much about understanding and being able to monitor like what's happening outside or in addition to kind of behavioral health and substance use core challenges. And the simplest way to think about it is as SDOH is going to have a massive impact on behavioral health outcomes, and being able to have that information and start to look at what care pathways work for whom, right? When we have, this demographic or this, SDOH challenge presented, what impact are we having with the programs we're providing with that, that population with? And do we need to think about, additional support? Do we need to think about making sure someone's connected externally? And if that's in place, does that affect the outcomes? And so being able to really drill down with data to understand, in the aggregate, what are the things we can do to better support individuals that do have presenting challenges outside of behavioral health and substance use. And that I'd say is like the most common way that our partners who are only providing the behavioral health and substance use services are thinking about this concept. All right, I think we can keep moving. Third topic here, which I think is a pretty interesting project that that Boundless gets to take on.
Yeah, so we're dipping our toes into universal screening by looking at some suicide prevention, and this part of the impetus for this is claims data that managed care companies have been looking at that really suggests individuals that either complete suicide or make an attempt are actively engaged in primary care, dental, and vision, really up to a couple days, couple weeks prior to their attempt. I think ultimately, when we're looking at universal screening, there's a huge opportunity to extend this kind of more broadly. But again, suicide prevention is where we're going to start in our clinic. And ultimately, what we're going to try to do is develop appropriate tools for our population, again, with some focus on the IDD-ASD population coming into any service in our health clinic. And so that would include primary care, psychiatry, behavioral health, ancillary care, speech and language services, again, eventually dental if we get that hygienist. And looking at screening mechanisms that work. So there's a little bit of validation into the specific population, but then using those screening tools to link individuals into treatment immediately, probably starting with some case management, health coordination, right when they screen, and then follow along again with measurement-based care to track symptom relief and functioning over their course of treatment. Again, thinking about that idea of where the savings occur, hoping to ultimately reduce emergency department hospitalization utilization in this population.
Maybe to try and highlight a few really practical elements that I expect will need to be in place, and like Nathan, you and I have talked about, that will have to go into this from a measurement-based care perspective. I think three things are, EHR integration, The second one, I'll just say tablets, but really the workflow. And then the third one is really ability to customize the assessments for a specialty population here, or to be able to have kind of multiple versions depending on kind of who's coming through the door, right? So on the first piece, anything like EHR integration is going to be very important to a measurement-based care implementation that we support in a behavioral health and substance use organization. However, many of our partners choose to not integrate with their EHR for whatever reason. In some cases, for whatever reason, choose to not integrate and can still run measurement-based care in a very effective way. When it comes to integration with primary care, we don't see a path where we're going to be able to do this effectively without EHR integration for a couple of reasons. Number one, pulling the primary care provider out of the kind of core EMR EHR system, we haven't found to be realistic, and not a hill worth climbing up. I'd say that the second piece is kind of ties into the workflow a bit as well, and so maybe I'll jump there. You need to make it really easy for a client to be able to do that measure when they walk in the door. And that integration enables you to, even if that client, they walk in the door, they've never been registered with the organization, if they're created as a client on that EMR, instantly that record needs to be available on the measurement-based care side, and the client needs to be able to easily surface that measure. So the workflow that's being contemplated here is one where, client is handed a tablet either in session or in a waiting room. They're prompted on that tablet to enter a code. That is something that doesn't have to rise to the level of complexity of a password. They're not signing into an account, but has to be unique to them and something they can remember. Something like last name, date of birth, as an example, or a health record number, or most often it's something around like last name or first last, year of birth, date of birth. So you're handed a tablet, add that information. Perhaps the administrator could add that information too. You hit submit, and then your measure is available for you to walk through. So having a really seamless workflow, I think, in a primary care setting and the integration to the EHR as part of that, like absolute table stakes. The last piece, which I think is particularly interesting here, is call it like assessment customization. So the ability to potentially add a video intro within an assessment to make it easier to understand, the ability to add images and make it a little bit less text-based, the ability to engage care providers or caregivers in the process as well, are all going to be considerations. And I think there's going to be, especially on this third element, a bit of like an exploration and learning and co-design process that we're going to go through that I'm particularly excited about. Now I'll bump the audience again. We've got lots of folks here. I'm hoping people are not shy, so feel free to add some questions, or we'd encourage you to add some questions, and we can either get to it in flow or in our last sort of 5 minutes at the end. Nathan, anything else you'd add on this slide before we jump to the last one?
No, other just to reiterate that I think, universal screening kind of more broadly, we have some projects in some schools and some partners, particularly up in the Toledo area that are implementing some universal screening in school settings. And it's I was going to say fascinating, but also disconcerting. I think the number of individuals that really are looking for immediate help when those screenings are done. So again, while we're starting here, I think the platform itself will allow us to extend into other areas of other service lines besides a health clinic. So for this one, this is perhaps a place where, agencies that are on the phone or on the call can substitute in their own unique populations. I think for Boundless, one of the things that is a challenge, particularly when you're trying to think about evidence-based interventions, thinking about how to measure, quantify the impact of the care that you're providing, is that the IDD population specifically, and individuals with more challenging behaviors and lower cognitive functioning are typically excluded from research because they skew the data. So, when we look at almost anything outside of again, perhaps the applied behavioral analysis space, you're kind of left struggling with, what does this mean for this particular group? I've had some recent conversations with some stakeholders around models of trauma-informed care, particularly in the residential space. And again, people having very strong opinions about what should be used and shouldn't be used. But the reality is, when you get into the research, none of those models are validated in this population. Not to say that they couldn't be, or somebody couldn't take the time to kind of do it, but the idea that you can pick up something that's worked elsewhere and say, all right, it applies here, it's just not true. Even lengths of treatment for any of us who are engaged in Ohio Rise and perhaps the PRTF space. I think I saw Steve Case on the list, so maybe this will resonate with you. Treatment length of stay 6 months. Okay, and there is data certainly in the SUD and severe mental illness space to say that length of treatment has diminishing returns after that. Again, not sure that applies in the IDD ASD space, and in fact, I think we would argue that at least anecdotal evidence suggests that treatment needs to be longer. So, here it really is, how can we take measurement-based care, screening, find things that work when there's communication issues, when there's cognitive issues, when you're relying on caregiver report, and still have that impact treatment positively, is something that we're very interested in. And it circles all the way back to those first two topics around how do we engage in that value-based care, alternative payment models, not, again, wait for somebody who doesn't perhaps have expertise in this population to decide how we should be measuring things, so that we can adequately advocate and support our mission, and how does that tie back to the whole person care. So
great. And I think there's, like, from my perspective, there's sort of two really important avenues behind a lot of these questions. Like, one, I obviously, like, my mind jumps a little bit to like the workflows and the technology and the implementation. Like, how do you actually roll out a kind of technology solution and process that can work really well in a specialty population? And it is always going to be an iterative process, and you're always going to learn at every step of the way. But the key is, you need to have that lens of trying to be flexible to learn and to implement in a way that can work. And then I think the parallel avenue is being able to look at the data on what's working, right? And I think it's in two ways. There's like an implementation exercise here, and also an evaluation research exercise here, that I think makes this particularly interesting and particularly important. And again, that same concepts, as you mentioned, Nathan, can apply whether we're talking about IDD, ASD, or other specialty populations. So we are at our last 4 minutes. I think first and foremost, like, obviously a big thank you again to everybody that's joined us today and taken an hour out of what's probably a busy week as we lead into the holidays. But also want to give that chance to kind of take any questions. And, Nathan and I could probably continue talking and chat away, and you're welcome to listen to us. But if there's any specific questions or topics you want us to focus on in the last few minutes, or if anything is unclear, I would encourage you to add them in the Q&A. Nathan, maybe while we give everybody a moment, any last kind of thoughts you'd share about either your perspective or the Boundless perspective on, why now, why invest, what's the, what are, you talked about the benefits you're hoping to drive, but anything else you'd add on top of that?
I don't know if there's anything else that I would add. I mean, I think, the part of the why now, I mean, Simon, I know we've been talking about this for a while. It's something I've championed for our agency for, probably a year and a half, maybe a little bit longer at this point. And certainly prior to that was thinking about maybe more typical or ways of trying to track outcome with pre and post, and what do we have in our EHR, and what makes sense in terms of visualization. But I do think that with the state's focus on mental health, at-risk populations, some of the increased rates that we are seeing and coming into effect from the last budget, there's a little bit of a space, I think, to at least for us to stabilize, kind of think a little bit about this next year or two of kind of not chasing growth to cover expenses and the things that we're doing, and really kind of refocus, reinvest back into the stability of our programs and set the stage for the next round of things that are coming. Again, I spent a lot of time in the IDD space and hear over and over and over again that, well, managed care is coming. And of course, everybody on this call knows that it's not only coming, it's been here. It's actually here in the IDD space as well, particularly when you look at how every child is in managed care and matriculate into adulthood in managed care. It's just got to continue to work and try to stay a little bit ahead of the curve, so that we can, support the populations that we've dedicated our careers to. And that's really what the work is.
Okay. Well said. Thank you, Nathan. Thank you, everybody. I think we can call it there at the top of the hour. But I appreciate it, and hopefully everybody enjoys the rest of their day.
Yeah, thanks for listening to us chat at you.